conversation continues. Post-partum haemorrhage, one of the leading killers of women. No, actually, Dr. says the number one killer of women in the country.
Correct.
These are very, 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 very high numbers that we're talking about. But the risk factors are known. And the risk factors can be detected early during antenatal visits. The risk factors, therefore, can inform the health workers what to do to save these lives. Okay, so where is the gap?
I think the gap is huge. Maybe I can illustrate this by a small story. And this is something which happened to me not too long ago in one of the private hospitals. I had finished a procedure I was doing, and I was going to change and go and do other things. And then one of my colleagues met me in the corridor, and he was shouting. He said, "There's horrible PPH, come to theater." I think theater 3 or theater 4. Right. So obviously that is an emergency. And I ran to that theater with my colleague, an anesthetist. And when I reached there, I found my colleague struggling. And when I asked, a quick history of the patient, said this was a young lady, 31 years old, who had come at term, that is at 40 weeks, and she had delivered a beautiful baby girl. And soon after that, she had started bleeding with nothing really was the cause. So, and she had struggled with this patient. And I said, okay, can I have a look? And said, there's a way that, a certain way which we are programmed to think when in such situations. Did she have any tears in the vagina? No, there were no tears. Just a small whatever, and she had put one stitch and there was nothing there. The cervix was okay, there were no tears, but believe me, she was bleeding like a tap. Wow. She would put what is called an abdominal pack, what we normally use for surgery, just to try and stop the blood from flowing. And after 2 minutes, it would be completely, soaked. So as we are doing this, I asked the anesthetist, "Have you given medications?" Said, "Yes, I've given 1, 2, 3, 4, and there are medications which you normally give in such a situation." And so I asked my colleague, "Can I have a look, fresh eyes?" So, and I looked, checked the vagina, checked the cervix, everything is okay. The uterus is contracted, but she's pouring. So when I put my hand inside the vagina, I felt that at the back of the uterus, there was a structure there. So my thinking was that possibly there could have been a fibroid, or there was a fibroid, and the placenta had been lying on the fibroid. So when the placenta came out, the vessels which were on the fibroid could not constrict, could not be blocked. So she was basically bleeding from there. So in such a situation, there are things which you think about and you want them to be done in a certain way. So I asked, do you have what you call a uterine balloon tamponade, which I have here. If you allow me, I can show it to you.
Please do. Please.
Yes, this is what you call a uterine balloon tamponade. It's a very simple contraption, I would say. This bit here goes into the womb, and in this bag we add fluid. We open here, and we pour fluid, about a liter of it, and then we hang it about a meter and a half above the patient. And what will happen is that
how long is that thing that you're holding?
This is about maybe, I would say, about 2 meters, maybe. Okay. I would say, yeah. So the idea is basically this plastic material that is here. When it goes into the womb, and we pour fluid, because now fluid will be going down into this, it will expand, and as it expands, it will block the vessels from bleeding. So I asked, do we have a UBT? No, there's no UBT. So what do we do? In the meantime, the blood pressure of this patient is actually dropping, and you can hear it on the anesthetic machine. I said, okay, get me a catheter. A catheter is basically a small tube which we normally use in the bladder when we are doing surgery. And we take this and insert it inside the bladder. Okay. So the idea of using the catheter, the principle is basically the same as this one. The only thing is that with the catheter, we need to put something here which will be similar to this plastic material here. And what we normally use is a simple condom. This is poor medicine for poor people because it is not used anymore.
So on one end of the catheter, it goes into
This one will go in. We have a condom, and do you mind if I open the condom?
No.
Yes. So we'd open the condom, and we would attach it now to the end of the catheter.
Okay.
And then we would actually take a suture and then tie it around here.
What is a suture?
A suture is basically, let's say, a thread. All right?
Okay.
What we use for surgery. So I would use this and I would tie the condom on one end such that there is no fluid which is going to be lost. Okay? There will be no leakage. Once I've confirmed that it is tight, then I would use a small instrument and insert this inside the womb. Once I've done that, I would now pour fluid through an opening here. And that fluid can be about 200, 300 milliliters of what we call normal saline. Any fluid can actually do in emergencies. So what will happen is that this condom will swell.
Yep.
And that is, as it swells, it will block the vessels which were bleeding. So I asked in theater at that time, do we have a catheter? Yes, there was a catheter. Meanwhile, remember, this patient is still bleeding. Can I get a condom? And there was no condom.
There's no condom in the hospital?
In theater.
In theater. Okay.
In the hospital for that matter.
Okay.
So after a few minutes, meanwhile we are struggling to control this bleeding.
Minute by minute.
Yes.
Right?
Yes. So anyway, one of the nurses strolled out and came back with a condom and said, "Excuse me, I wanted to say something. I got a condom, but I want to say that it was not in my handbag." We say we don't care where it was.
This is not the time for that conversation.
We don't care. just give it to us. Just give it to us. No. So when we fashioned this is basically a uterine balloon tamponer, just like the one that I showed you, and we inserted it inside the womb, and we pushed in fluid, about 250 milliliters. The bleeding stopped.
It blocked the vessels?
It blocked the bleeding and it stopped.
Okay.
We put in another abdominal pack just to make sure that everything is okay. And after it stopped, this patient was transferred to ICU. It was on a Friday. When she came to hospital, what we call her HB, that is the amount of blood that she had, was 11 grams per deciliter. The normal is between 11 to 13 to 15, depending on what lab you're using. When she went to ICU, we checked, because we do that before we give blood. Her HB was 3.1.
Wow.
Yes.
She had lost that amount of blood.
She had lost about 2 liters of blood. So in essence, she was on her way out. A healthy young lady delivered a healthy baby, came into hospital walking. Potentially she could have gone out in a casket, in a box. She went to ICU over the weekend. She was given blood. She was given medications. On Monday, she was as bright as day. She went home with her baby. What saved that woman?
Hold on, Dr. Ari.
Yes.
At what point was this thing removed? The condom.
24 hours afterwards.
So you just
We just insert it, and once we assure now the uterus is well contracted, there is no more bleeding. We just remove the fluid, and once the fluid has come out, the condom will collapse, and then we just remove it out.
How do you know that the uterus
has contracted?
As contracted, by checking, by just massaging the abdomen, we can actually feel that it is hard. And we know that it is well contracted. Because when it's not well contracted, it's soft and it's boggy. And then apart from that, we know the size of the uterus as well. Because we know after delivery, it should be around, let's say, 18, 20 weeks. But if it's 28 weeks, 25 weeks, and it's after delivery, something is not okay. The uterus is not contracting properly.
There was a mention of fibroids, or the possibility of fibroids existing.
Yes.
Did you confirm that indeed there were fibroids? And if so, what was done?
It was my theory, because we would have had to do a scan. But at that moment, what you need to do
Was to stop the bleeding.
stop the bleeding.
Yeah.
That is the most important thing.
So what would one do in such cases? She's gone home.
Yes.
Would she then be asked to come back so that she can have other tests to determine what it is the problem was? Because if she's young and she wants to have other children, What then happens if you have a repeat performance?
Now, immediately what happened, maybe I can go back a little bit before I answer your question about what are the issues.
Yeah.
And I use this as a prime example. And it is something which happens to or can happen to any of my colleagues who is practicing obstetrics, whether it is in the private sector or in the public sector or in the faith-based or whatever it is. This is something that can happen to anyone. That is why we need people who are experienced, people who know what to do, and people who will not lose their heads when they see so much happening at the same time. Because remember, here you are listening to what the anesthetic machine is telling you, and here you are trying to find out what the problem is and solving it at the same time. And time is of the essence. Several things actually helps us to save this woman. Number one, we were 3 consultants. There were 2 obstetricians and an anesthetist, very experienced. And we knew what to do and where to do it. Number 2, there were medications. Quality medications. A study was done not very long ago, actually by a group of my colleagues from the university, Department of Obstetrics and Gynecology, and this was a study done in Kenya, I think it was Tanzania, and Nigeria and another country, where they looked at over 240,000 pregnant women who delivered. And they also looked at the quality of the medications that these women were getting. And unfortunately, it's very sad to say that in Kenya, some of the medications they were getting, and it was a random sampling, was actually poor quality medication. What do I mean by that? It means that medication X, which says it should have a certain chemical of certain strength, 10 units, 10 milligrams or whatever it is, it was found that it was not actually true.
It had more or less.
It had less. So you find you are giving this medication and you are expecting the uterus to contract and it doesn't contract. And you give more and it doesn't contract. So you are wondering what is happening. So quality medications. We had quality medications. Number 3, we had blood. Blood is a problem in this country. We collect as a country 276,000 units of blood, which is about 60% of what the country needs. We need about 500,000 units of blood per year. And guess what? 70% of these 276,000 units are used by who? By women who are expectant, who bleed during delivery or after delivery. This hospital had an ICU which was well equipped, it was functional, and it had people who were trained to actually monitor these patients. Now, these are what you call pillars. And then, of course, there are consumables, where, of course, we got the condom and so on, and so on. So you have human resource, which are the doctors and the midwives as well who are working with us. We have medications, quality medications. We have blood. We have consumables. We have an ICU, which is functional. Unfortunately, in most of our hospitals, government hospitals, you may not find all these pillars, all of them at the same time. In one, you may find, yes, the consultants are there, but there is no blood. You may find the consultants are there is blood, there are no medications, there are stockouts. The consultants are there is medication, there is blood, there is no ICU. Or if there's an ICU, it's a caricature of an ICU. You have a building, but nothing more. Or you have a building which has machines, but you don't have people who can actually monitor these patients. So these 5 pillars, if any one of them is lacking, then unfortunately we are going to lose these patients. And most government hospitals, you will find that 1 or 2, or sometimes all of them are missing. And that is the tragedy that we are looking at. In the meantime, in the morning, I heard City saying there was how much? 17 billion, which was used for
17 billion. Governors and MCAs.
That's what people in the county, yes,
They traveled here and there. Morocco, Singapore, Tanzania, Uganda.
Yes.
Yeah.
Yeah, which is sad, unfortunately.
This is the thing. It's about the investment in healthcare.
Correct.
On all these aspects that you've said. We invest in training doctors, clinicians, nurses, and everyone.
Yes.
We invest in having the facilities and equipping the facilities.
Correct.
And making sure that everything is working.
I did a small sort of a study, call it a study. I asked my colleagues from the office, that is the COGS office, to call all referral hospitals, county and sub-county hospitals, 98 of them, just to find out how many of them have this, what you call the uterine balloon tamponade. First of all, about 42% of them declined to answer our question. It was a simple question. We are calling from COGS. This is the Kenyan Obstetrical and Gynecological Society. We just want to find out, do you have something called a uterine balloon tamponade? They said, first of all, who are you? This is a government hospital. We don't give information. And so on.
Ask the ministry.
Now, of the ones which did reply, I think there were about maybe 4 or 5 of them which actually had this in store. 4. Others had never heard about a UBT. So, and this is something which is
What percentage had never heard?
If you remove the 40% which said they cannot give information because it's government, so we are left with 60.
Yes.
Of the 60, I think about 4 or 5 of them had them stocked. I would say maybe about 20 or 25 of them had never heard about UBT.
Never heard.
Never heard about UBT.
Kenneth Omondi is asking, ask Daktari, is the reproductive health division at the health ministry still functional?
It is functioning.
Where functioning means what exactly?
Where functioning, I'm not holding forth for the reproductive health division.
Well, you said it is functioning. I want to understand what you mean.
There's an office.
Yes.
And there's a director.
But we do meet as COGS. They call us for meetings, and we are in technical working groups, and we've been working quite handily with them. I must say that they have done something which is very, very good. They have spearheaded the availability of one drug, which is called carbetocin. And this is available because I talked with one of the guys and they told me that they had imported, I think, 260,000 vials, which are available in KEMSA. And this drug is one of those basic requirements, basic treatments that we use in such cases of postpartum. So in that respect, that's why I'm saying it is functioning. They have done that, which I think is commendable. However, I think we can do a lot more.
There is data that indicates to you clearly regions where perhaps this condition we are speaking of is higher than others.
Correct.
Now, if we were to do a different survey and ask this very critical medication,
yes,
does it reach the places where it is most used? Because I'm asking the question from the point of view of the procurement process. We understand, we are told about them, we tend to understand them.
Correct.
We're even told where the drugs are domiciled. But when you get to where it is needed, there always seems to be a problem. We even saw that with the COVID.
Yes.
When we were being told that, yes, the vaccines have arrived, okay? They were even escorted. They're in this central place. But before they got the act right, places where they were needed, one did not find them. When you ask, you're told that they are there. You go, actually, we are there, and they're not there. So we don't understand. That's why I asked that previous question. Do these things get to where they're most needed?
I would say that sometimes, yes, they do. And sometimes they are stockouts. And then the procuring process also has an effect. So, yes, sometimes they are there. And unfortunately, most times they're not there. That is just one of the problems. We have counties whereby you have, let's say, 2 consultants in a county. 1, 2.
By consultants, we mean OBGYNs.
OBGYNs, 2 consultants in a county.
For the entire county.
For the entire county.
Right.
Yeah. So you remember I talked about human resource.
Yep.
As one of the pillars. So if you have 2 consultants in a county, there is no way you are going to be able to actually save these mothers.
Can this knowledge, at least a bit of the knowledge, be transferred to the other doctors? The
Yes,
clinicians who are in hospital?
Yes, it can.
And I want to ask that question as I head back into risk factors are known. Risk factors can be detected early during the antenatal visits into hospital, right? If a woman who is expecting a baby is seen to have these risk factors, is there something that can be done to reduce the effect, to reduce the chances of them having PPH?
Yes, something can be done. And what are these things that can be done? Number one, I think the knowledge of that you're pregnant, because most people say being pregnant is not a disease. This knowledge should actually go out there. Say, when you're pregnant, please visit your doctor, your healthcare facility, and so on.
At least how many times during the pregnancy?
The WHO recommends 8 contacts. Some of them come without any contact at all.
Wow.
Some of them come without having even had a blood test done. And anemia, we know, is one of the risk factors as well of PPH. Some of them don't even know their blood group. So there are quite a number of things which can be done. But if they were to visit their healthcare facilities where we have midwives, we have doctors, and so on. These are things which can be picked up very, very easily. That is number one. So we identify these patients who are at high risk. Number two, we need to retain them. What does that mean? We have identified that Madam Joyce has a problem, or Madam Joyce has a high risk of PPH.
Yeah.
So how do we follow her through? What are her contacts? How can she be better followed? So the retention bit. And then the other one is, how do we respond to what we have?
Yeah.
We say, okay, we've identified you've had 4 or 5 babies, and they have been big. So please make sure that you come, at given times for follow-up. And then when it gets to the time when she's supposed to deliver, where is she supposed to deliver? These women are supposed to deliver in places whereby they have these pillars that I mentioned about. We
So
have
about a
expertise.
level 4, level 5.
Level 4, level 5. Just by doing that, we will have reduced a huge amount of these women who die because of falling through the cracks, and then they go to deliver. Sometimes they have home deliveries and so on. The uterus does not contract, the placenta does not come out, and so on. Birth attendants may not actually have an idea about the physiology and pathology of such women, so they think it's just a normal delivery, and then things go south. And when they go south, they really, really go south.
Do the medics know this?
Yes, they do. Actually, whenever our students rotate in our department, in obstetrics and gynecology, this is one of the things that we emphasize about, the big 5. And there is something that we are planning to do. We are planning to put sort of algorithms of what to do in these big 5, such that when these medical students, interns basically, go out there, they have something like a booklet where if they see a patient, come into contact with a patient with preeclampsia, do 1, 2, 3, 4,
Right.
stabilize the patient, refer. If there is post-partum haemorrhage, do 1, 2, 3, 4, stabilize. And if you're in a facility which cannot handle such a patient, then refer. But then there are also other issues. There are issues of infrastructure. Roads may not be okay. You can do all this, but you find that the infrastructure is not okay.
No
Ambulances
ambulance.
are not there,
Yeah.
etc.
We have to properly invest in our healthcare, and there are no questions about it. Dr. thank you very much for joining us.
Thank you very much. I would like to invite you for a run that we are organizing on the 6th of October. And this is basically to raise awareness about PPH. It's a short run from Ulinzi Complex all the way to Nairobi West and back.
How many kilometers are those?
That's about
That's
10 kilometers only.
Okay. Are we allowed to walk?
We are allowed to walk. We are allowed to ride a bike. We are allowed to
Just cover the distance.
6th
of October.
6th of October, and you can register at endpph.com.
npph.com. And PPH is post-partum haemorrhage, which is what Dr. Kireki Omanwa, who's the president of the Kenya Obstetrical and Gynecological Society, has been teaching us about this morning, understanding postpartum hemorrhage and why it's the #1 killer of women in Kenya. Keep it here for more conversations. It's 8:01.